Hi, my name is Dr. Ali Davies. I'm going to present to you a study that I'm currently undertaking with my colleague, Dr. Jiao Song, on housebound patients in Wales, the incidence, prevalence and characteristics. So I'm a GP by background. I'm a clinical research fellow at the Division of Population Medicine at Cardiff University, and Dr. Jiao Song is a statistician with Public Health Wales. So I'd like to apologise as well that I can't deliver this presentation live, and that you're going to have to put up with my ums and ahs and navigating the technical aspect of recording a PowerPoint presentation. So what does it mean to be housebound? I think that it's a fairly obvious question with a fairly obvious answer. Somebody who's stuck at home and cannot leave their house. But actually the reality is it's a bit harder to be clear about this. It's not actually a medical diagnosis. Is it a social label? Is it somebody who is physically unable to leave their house all the time, or maybe just part of the time? And what role does mental health problems play in patients or people who are housebound? Can somebody also become unhousebound? So somebody who is then becoming unhousebound. So I guess we all have a traditional image of what it might look like growing older. And here's a nice image of a healthy group of people who are maybe a little bit older. We have other images, such as this one from Last of the Summer Wine. And we might then also have this image as well. So this is something that as a GP I've encountered on a number of occasions. Maybe elderly patients who are not only housebound but bedbound and needing lots of care at home. So what does the current literature tell us about the incidence and prevalence of housebound people maybe across the world? So, importantly in the UK, there really is not much data here at all. In Israel, for example, they looked at an older cohort of people between 75 and 95 in a cross-sectional study, and they reported a prevalence of 17 to 19.5%. In Spain, again, they looked at people over the age of 50 and reported this prevalence at about 9.8%. In the US, it's been reported as 5.6%. These are all cross-sectional studies, and I think there is an issue there in terms of the reliability of these results. And obviously, they do show quite a variation. So why look at this area? I think, personally for me, the COVID-19 really did open a lot of things about identifying vulnerable patients in primary care, needing a way to identify people who might need, that we might need to go out to deliver vaccines, for example. And it really did change the way that we look at this problem, or this cohort of people, certainly. I mean, we've got an older population, not just in the UK, but around the world. There is a drive to look at care closer to home. There is a need to identify people on the periphery of society. That's not just elderly, frail people, but other people with learning disabilities and so forth. And like I said, COVID certainly had an impact. We needed to identify our vulnerable patients. We needed to be able to identify those patients where we need to be proactive and go out to deliver care. I think this issue around reactive and proactive care, I think is something that struck me particularly within chronic disease management. So a lot of patients who are housebound that I've encountered, the care is quite often reactive. It's not proactive. So chronic disease management tends to get sidelined, and we are dealing with patients' acute problems and almost bumbling along. And what often happens in those situations is that the chronic disease problems become more acute, and care then often becomes quite unpredictable, and people can end up in acute settings rather than their care being managed appropriately in a proactive way. And really, the other thing that I've sort of wanted to look at here is are housebound patients different? Are they different to the non-housebound patients? Again, you'd think the answer is quite obvious. I think having an answer to that would be beneficial in terms of delivering healthcare. So how have we tried to answer this question? So for me, SAIL was the obvious answer. It's a huge amount of data from various sources. So we were able to combine data from the GP data set, emergency services, hospital admissions, and demographic data sets. And I've got a list here of the data sets that we've used within this study. So the annual district death, the emergency department data set, the patient episode database Wales. So that's the PEDU, and that gives us a lot of the information about the hospital side of things, the Welsh demographic service, and the primary care or the GP level data. So when we ran the search within the GP data set, this was the main data set that we wanted to look at, because we're really interested in how GPs are identifying patients who are housebound. So there is a specific code within the GP system that can be used to nominate a patient as being housebound or not. And we searched within the GP dataset for this particular read code. It's only one, so it's quite straightforward. And when we ran this code, we found that 87,000 plus patients or people were identified as having a housebound code within their records. We then wanted to drill down a bit more specifically to identify unique patients. So there were some patients with multiple codes of housebound in their records. We also had to do a bit of data cleaning, as you have to do with any data set and when you're looking at and analysing results. And what we found was there was 197 patients were identified that didn't have a date of birth. So we removed those from this cohort. 20 were identified as coded housebound before the date of birth. So that would come down to a coding issue. And 176 were identified as coded as housebound at the date of their death or after the date of death within the GP record. So we've taken them out because actually we want to know a bit more about what's happened to them after they become coded as housebound. So what we're left with then is a final cohort of 57,478. So within this cohort, we have looked at some of the demographics, and a bit more patients were female compared to male. The mean age at the time of coding of becoming housebound was about 81 years. A bit of a standard deviation. The age range, the majority of them fell into the category 80 to 89 and 90 plus. But we were seeing patients that are being coded as housebound. There were some children, and then there were some, quite young as well. We also then wanted to look at the Welsh Index of Multiple Deprivation. And I think this is a very important thing for us to look at, because we want to know whether people who are housebound, do they live in the most socially, economically deprived areas of Wales or the most affluent areas? And the answer is it's a bit of both. So as you can see, the most deprived, and so number 1 and 2, so we looked at quintiles. And there's a downward trend from the, so the majority of patients were found in the most deprived areas, and it's a downward trend, but actually seems to be going up then in the most affluent areas. In terms of recording of death, so of that cohort that we originally found, 18,000 patients, 700 plus, but 32% are still alive at the time of analysis. So obviously that meant 38,700 had died. And we looked at the time of to death from coding, so a time to event analysis, and the mean time from being coded housebound to then dying or to death was was nearly 3 years. So that means that generally people are being coded as housebound. There's a period of round about sort of 2-3 years where they are still alive, and we wanted to look at maybe some of these characteristics of these patients. So in terms of diagnosis at death, the main sort of diagnoses that we would generally see in the population were what we were seeing in housebound patients. So cardiovascular disease, respiratory disease, cerebrovascular events, dementia, and lung cancer. These are the 5 most common diagnoses or causes of death that would be identified in this housebound cohort who had died. In terms of geography, I guess when I started this study, I probably would have had a preconceived idea that there were probably more housebound patients in rural settings because of an older population. But in fact, what we found was that the numbers are quite consistent across local authorities. So we can look at some local authorities such as Gwynedd or Anglesey as maybe being more rural, and then local authorities such as Cardiff or Swansea being more urban. But in fact, there was really no obvious difference between rural and urban settings. So the actual incidence and prevalence, so this is where we have got to with this study so far. So we've looked at the numbers over the years, and what we found is that there are actually low levels coded as housebound. So so around 0.05% of the population of Wales in 2011. And what we see over time is that this slowly increased, and surprisingly, there was a very large increase in 2020 and 2021. So this incidence for Wales overall went up by 0.05% to 0.5%. So quite a significant and big increase in the number of people coded as housebound in the GP record. So what next? So our next stage in this study is to create a matched cohort by age, sex, and GP practice. And we want to look at the comorbidities using tools such as Charlson Comorbidity Index and the Electronic Frailty Index. These will be able to allow us to create, to look at maybe differences between housebound patients and non-housebound patients, look at their comorbidities and healthcare utilisation between these two cohorts. So I'd like to apologise that I can't present and then obviously field questions in person, but I'm more than happy for people to contact me via this email address. And I hope that you found this presentation interesting, and hopefully you've gained some better insight into the world of patients who are housebound. There is still a lot of work to be done, and I hope that I can complete and finish and present this completed piece of work in the near future. Many thanks, diolch yn fawr.